We will continue with the session now. The theme is post-operative pain management. I request Dr. Amit Dixit.
Good morning everybody. पुणे तिथे काय होणे, सगळं काही पुण्यात छानच आहे. Glad to be back in Pune. I am given with a talk, post-operative pain management in orthoplasty. I was wondering all who's who in anesthesia are here, why they are giving it to me. I am coming from Ganga. You are all welcome to Ganga. I am inviting you on behalf of Ganga family. We have this Indian scenario. 7 days later, we have undergone the surgery for one limb at a time, and then after 15 days, we had this outcome. We are glad to be, we feel contented that we have made a difference, and we all can have the same effect. Now, my talk is divided. Today I am planning to divide my talk into, I'll just assess literature review, Indian scenario, and practices at Ganga Hospital and take home message. What is an orthoplasty procedure? Like this, everybody has seen. Orthoplasty is, there is an iatrogenic fracture which itself will cause pain, and all these TKR patients are made to walk, somebody by at the end of 3 hours, 5 hours, or at the end of 24 hours. So to make that fracture segment work and walk and to have some sort of physiotherapy is very painful. What are the challenges then? Control of pain, we would like to achieve a VAS score of less than 3, and early mobilization as per your surgeon's protocol, depending on your institute. Now what are the modalities of pain management? As we look into a history of anesthesia, we are slowly progressing from central to peripheral. Centrally acting, initially we have all systemic drugs like opioids. Slowly we are moving towards periphery. We are trying with epidurals, then now on nerve block, and recently local infiltration analgesia. We all know that as we move towards periphery, complications, adverse effects are less. If I say loco-regional opioid sparing multimodal analgesia is mantra of the day, I may not be wrong. What are the analgesic modalities then available to us? They are paracetamol, NSAIDs, gabapentin, subanesthetic doses of ketamine, alpha-2 agonist. These are there, they are to be received. These are the essential component which I'll be using for all my patients. Incorporation of regional technique, either local infiltration or nerve block with or without catheter, epidural, either of these or combination of this is a good idea. Opioids, as we all know, morphine, PCAs, backup plan for everything. What is local infiltration analgesia? When we look at literature, this is 2012 Chittaranjan Ranawat Award, Chittaranjan Ranawat Pioneer of Orthoplasty. This paper has received the first award last year. Case was done under single shot spinal, local infiltration analgesia was given, a LIA catheter was placed, and 5 ml elastomeric balloon infusion pump was used for post-op analgesia via LIA catheter. They found scores pretty okay, and it was like one of the best paper. Another study, another association of orthopedic surgeons, they are now more into fast tracking, they are more into LIA, they are discussing as a part of protocol. Now local infiltration analgesia not only has a role in TKR, but there is a proven literature evidence that it is helpful in orthoplasty procedure as well. Now what is a LIA mixture? This was from Ranawat. Ranawat is, they have Ranawat mixture. As you can see, it is bupivacaine, morphine, epinephrine. By and large, if you look at literature, LIA is a mixture of local anesthetic, epinephrine, ketorolac, clonidine, and normal saline. Total solution is up to 50 to 100 ml. It has to be distributed in 4 different quadrants. Now I'll be discussing about, this is from a Journal of Bone and Joint Surgery, where the drug has to be distributed equally into all 4 areas. First area is a posterior capsule, second is medial periosteum and medial capsule, third is lateral periosteum, lateral capsule, and Fourth is a soft tissue and skin, 25 ml in all these area. Unless somebody is really meticulous in distribution of this drug, the drug will not work. As you could see, this is posterior capsule infiltration. If I am able to sensitize my surgeon with recent evidence, and if he is okay with all that, and somehow I am able to convince my surgeon about for betterment of my patient that how LIA is working, then this 25 ml posterior capsule distribution will take care of your sciatic block. The lateral and the medial gutters of femur, the solution has to be infiltrated not only into the skin and subcute, but also into the periosteum, bone and muscle nearby. LIA, when compared with other modalities, ample of evidence to show that it is better than continuous femoral. People are discussing about pain chronicization. LIA has been found beneficial to prevent chronic pain. LIA and fast tracking. With LIA, as you could see on the left hand side, the mobilization at the end of 3 and 5 hours. Opioid use is minimal, and people are going ahead with a single shot spinal. Practical problems with LIA, when I think of applying it to Indian scenario, is surgeon factor. As I was discussing, we can get this evidence for LIA, have an intellectual discussion with our surgeon, try to convince him for betterment of our patient. Whatever mode of analgesia you are trying, if you add LIA to it, the quality of analgesia will be better. Second is, as Dr. Manikandan was discussing about the aseptic precaution and clinical pharmacologist preparing the drug, if we are little proactive in preparing the LIA drug by our own self, then we'll definitely be able to provide a sterile solution for surgeon. So unless we are little proactive, things will not work. Apart from LIA, now the other modalities are nerve block, lumbar plexus. For hip surgery, it is lumbar plexus with or without catheter, femoral nerve block with or without catheter, sciatic block. When I am talking about look into the literature of lumbar paravertebral block, everybody will agree that this is not a very simple block. Block is at a deep seated level. Areas of concern: if hematoma happens at that level, I will not be able to compress. Secondly, the dural sleeves are very near. I may end up giving epidural or intrathecal dose. So this type of word of caution while using this type of blocks for hip surgeries. Good news is continuous femoral when compared with lumbar plexus block for hip surgery. If your femoral catheter is in place, it is providing you equally good analgesia. Blocks in TKR, femoral block with or without catheter. Yesterday Vincent Chang sir was discussing about whatever we try, quadriceps weakness is a lot of a problem, and so instead of giving a proximal femoral block, we are now moving towards adductor canal block, and where we will have less of motor weakness. Sciatic nerve block, single shot is always often used. Now, looking at the literature, what is the Indian perspective? As I have shown my first slide, how our patients are. In Ranawat clinic, as I was discussing with one of our surgeon who was trained in Ranawat hospital, he said that people are unable to play golf, they then get themselves operated for TKR. Sometimes if they are the physical restraint, they are not able to walk more than 1 kilometer, then they are so much conscious about it, they visit an orthopedic surgeon and get their TKR done. So that much if I say epidural is gold standard, my question is why not? Is there any evidence? This is the recent one from Cochrane library. It showed that the benefit may be felt in first 4 to 6 hours after surgery. This was published when they have compared epidural versus all modalities of analgesia. They have found that benefit, a good quality of analgesia is definitely there for 4 to 6 hours, which can be applicable for our patients who are coming initially in absolutely crippled stage. Factors favoring epidural, there are patient factors. Now if I am thinking like I'll not be using epidural, then what are the options intraoperatively? Either it is spinal or GA. But when I look into patient profile, my patients are most of the time are elderly with multiple comorbidities. It is very difficult to give single shot spinal. I may end up giving a high dose. If I have a epidural on board, I may start with a little low dose epidural and case can be started easily. Other factors are, as you can see, most of the patients coming to our hospital are coming on wheelchair, they are bedridden from almost 4 or 6 months. We don't expect them to run or walk at the end of 3 and 5 hours. Indian scenario is different. We have to accept it. Other factors are like surgeon factors. Not all surgeons are willing to mobilize their patient at the end of 3 and 5 hours. Some surgeons would like to use continuous passive mobilization. Anesthesiologist factors are also there. We are on the learning curve of regional anesthesia. Not everybody is proficient with shared ecofemoral and placement of continuous catheters. What I would like to say is, like, when I have to decide some plan for my own patient, I would like to consider patient factor, surgeon factor, and when goal is clear, I think path is not shaky. Path is also clear. And my goal is clear that I want to achieve VAS score of less than 3, and my analgesia management should be such that it will not affect the physiotherapy or early mobilization program. Now, if this goal is clear, then it can be achieved by LIA, it can be achieved with nerve block, or why not with epidural? We are trying it and we are doing it every day. Lessons learned at Ganga Hospital: we are doing a multimodal analgesia. Paracetamol, NSAIDs, gabapentin are a part of our regime. Surgeons are, to our good fortune, are sensitized with LIA technique there, where we are using 50 ml of 0.3 bupivacaine, morphine and epinephrine. We are using combined spinal epidural. Now, if patient is complaining of pain post-operatively on epidural, I am saying, why not? Why you should have a functional block? That patient who is on epidural should be continued with epidural only. Why not try a rescue femoral nerve block? That is what we are trying in Ganga, and results are good. Instead of putting a patient, trying with the epidural, hypotension and numbness on one side, other side, all the time stopping the drug, why not do a rescue femoral nerve block? 80% of the patients are comfortable with that. 10 to 20% we have also given a rescue femoral block, and this has worked well for almost 6 to 8 hours. Multimodal analgesia, take home message is multimodal analgesia is a must. Paracetamol, NSAIDs, dexamethasone, pregabalin to all patients. Incorporating regional anesthesia, either epidural or nerve block or LIA or combination of all of this, depending on your infrastructure, is a very good idea. Thank you very much for patient listening.
I am proud to have Dr. Amit Dixit. He is the first postdoctoral fellow who is going to give his regional fellowship exams in the recent months to come, and we wish him all the best. And he is from Ganga Hospital. He is being trained under Dr. Bala. Thank you very much.